Welcome. Thank you for joining us for today's Knockout Opioid Abuse Day Learning Series webinar, Community Strategies to Fight Opioid Addiction. A few housekeeping items. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, and one ADA CERP continuing education credit by the American Academy of CME Inc. And for any pharmacists claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has also been approved by NJOEMS for one EMT elective CEU. And the Partnership for a Drug Free New Jersey is approved by the Board of Certification, Inc. to provide continuing education to athletic trainers who are with us. This program is eligible for a maximum of one Category A hour or CEU. PA Planner Dean Barone discloses that he serves on the speakers bureaus of Ethicon and Johnson & Johnson. And all other planners, faculty, and reviewers have no relevant financial relationships to disclose, and all relevant financial relationships have been mitigated. If you wish to claim CME or CE credit, you must do so within 30 days from today's date. After that, we will no longer be able to issue credit. And as Greg mentioned, information on obtaining credit will be available at the end of the webinar. Today's webinar is jointly provided by the Partnership for a Drug Free New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares, the Office of Alternative and Community Responses, the New Jersey Office of the Attorney General, and the Opioid Education Foundation of America. And I thank them all for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. And I'm so pleased to have our expert speakers and faculty with us today. We have Tiffany Wilson, Esquire, who serves as Senior Counsel and Director of the Office of Alternative and Community Responses for the New Jersey Office of the Attorney General, and Dr. Melissa Pielick, a licensed clinical psychologist and assistant professor at Brown University's Warren Alpert Medical School and the Center for Alcohol and Addiction Studies. And I thank you both for being with us. We're looking forward to your presentations. And Dr. Pielick, I'm going to turn the presentation over to you.
Wonderful. Thank you so much, Angela. And thanks to all for the opportunity to present today and share with you some of the research I'm working on in partnership with our communities. So the focus of my talk today is on pain management as prevention and intervention. And I'll be sharing with you our work partnering with youth and families to develop a brief intervention targeting pain coping and substance use before wisdom tooth extraction surgery. Next slide. As Angela mentioned, I don't have any conflicts of interest to disclose, and my work is funded by NIH through the National Institute on Drug Abuse, which I'm very grateful for. Next slide, please. These are our learning objectives for today's session, and in colors there is just connecting it more directly to my work and the content I'm presenting today. So first I'll walk through briefly trends in youth opioid and other substance use. Next, we'll move into talking a bit about relations between pain, substance use, and approaches to acute pain management, and why I'm talking about pain in the context of addressing youth substance use. And then finally, sharing a bit of data from our formative work, developing this intervention with feedback from our youth and family partners. Next slide, please. Before I jump in, just want to share a bit of perspective from where I'm coming from as a pediatric pain psychologist and researcher working in spaces of both pain and substance use in youth. And what's been so interesting over the last decade doing this work is just seeing the commonalities between these two fields and these experiences. Both chronic pain in youth and substance use are surprisingly common, have high chance for negative short and long-term consequences and costs to youth and families as well as society. Next slide. The other piece that weighs heavy on my heart in the context of this work is that both youth pain management needs and substance use tend to be overlooked, under-recognized, and undertreated. So there's so much space to do, so much work to do in both of these spaces to better meet the needs of youth and families. Next slide. And then the last piece I want to acknowledge is is, working in both of these spaces, there's such strong parallel narratives that are going on. With my pediatric pain colleagues and families, I hear stories of youth pain being dismissed, undertreated, not being able to access medications that are really important for their care. And yet, on the other side of things, in my work volunteering with our family task force in partnership with our governor's overdose task force, I work with families who have lost loved ones, children, to opioid use and other substance use. And both of these narratives and these problems are so valid and so important. And yet it can be hard to see where there is a bridge and where there's space to address them both. Next slide, please. So I just want to spend a few minutes talking a bit about trends in youth substance use. Next slide, please. As I mentioned before, substance use in adolescents and young adults, AYAs, is fairly common. Next slide. And what's really important to note in this time period is that adolescence is the peak period for initiation of substance use. In these graphs here, you'll see on the bottom is age at first use in years. And you see that big sharp jump upwards. That's it between the age period of 10 and 20 years old. So there's this rapid escalation in use in these teen years, which also suggests and points to there's a really key opportunity to intervene and both prevent and also intervene on current substance use to try and mitigate harm and mitigate the trajectory of ongoing use. Next slide, please. So some good news, folks may have seen this data that came out last year, is that by and large, over the last few years, teen substance use rates have been declining. And this is specific to use of substances other than cannabis amongst 12th graders. Next slide. The not good news is that in the context of reducing substance use among young people, overdose death rates in teens in particular continue to rise. Next slide. And so what we see here is this kind of divergence of we're reducing use, but the risk and the consequences are increasing, which suggests that the consequences of youth substance use are escalating, and that there's so much more work and that we need to address beyond just reducing use. Next slide, please. And just to kind of put this into perspective, in this piece here, every week in 2022, the equivalent of a high school's classroom worth of students, an average of 22 adolescents died of a drug overdose in the United States. So the overdose crisis oftentimes gets overlooked in adolescents and young adults because the frequency and prevalence of opioid use disorder is fairly low in this population, but the impact is still so great and so real. Next slide, please. And just diving into the numbers a bit, by the end of high school, about 50% of youth report past year alcohol use. Next slide. About 1 in 3 youth report past year cannabis use, and this includes all forms of cannabis. And then by the end of high school, about 1 in 4 youth report using nicotine or tobacco. Next slide. And what I don't want to lose sight of in this is that there still is a substantial portion of youth that are abstaining and that are not using substances. And that's something that I think I always try to highlight when I'm talking about brief intervention with youth with substance use, is that brief interventions also provide an opportunity to provide reinforcement and provide praise and support for youth that are not using as well. Next slide. So when we're talking specifically about opioid use in youth, data from the National Survey on Drug Use and Health, NSDA, suggests about 1 to 2% of adolescents report using opioids in a way differently than prescribed in the past year. And we do know that leftover prescriptions, whether it's from themselves, a friend, a family member, continue to be a primary source of using opioids differently than prescribed in youth. Next slide. In regards to rates of opioid use disorder in youth, about 1% meet criteria that we know of, and about 0.1% report fentanyl use. Although I feel like that gets increasingly challenging to measure and hard to know, just with fentanyl being in our drug supply and whether people are explicitly seeking that out or whether it is in other things they're using. Next slide. And particularly when we're talking about youth substance use, it's really important to acknowledge polysubstance use because oftentimes youth are not just using one substances. Polysubstance use is particularly common with adolescents and young adults, and particularly common in the context of opioid use. Um, this data, which is a few years old now, but in 2018, polysubstance use involved deaths, overdose death rates surpassed those of opioid only death rates among young people. Next slide. And so a question that I commonly get asked in clinical research spaces is this acknowledgement about substance use being normative in teens, developmentally normative for risk-taking behaviors, experimentation. And while that is certainly true, and while that is something that teens engage in, next slide, we can't lose sight of the fact that substance use, especially in teens, is not without risk. When we're talking about risks, we're talking about implications on school and academic functioning, mental health in particular. The rates of comorbid mental health disorders and substance use disorders in youth are very, very high, and also legal consequences. Next slide. And if there's like one thing I want you to take away from this first part of the talk, is this piece here that when we're talking about substance use in adolescents, it's not just about substance use disorder and meeting full criteria for an alcohol use disorder or cannabis use disorder. More times than not, consequences of adolescent substance use are not necessarily related to addiction, but more so related to the fact that all substance use confers some risk. And this is particularly true in the context of opioid use with youth. Next slide, please. And lastly, as I'm wrapping up this section, just underscoring again that the age of first exposure and initiation of use is related to increased risk of substance use disorder and continued use into adulthood. Next slide. And so the thing that is that also weighs really heavy on my heart in the context of this work is that we have evidence-based treatments that we know are effective for treating, addressing, intervening on youth substance use. And the reality is that less than 1 in 10, and some data sets even say only like 3% or 4% of youth who actually need substance use disorder treatment get it. And that is huge. That is such a small subset of youth at such an important and a critical point in time, which from my work in implementation science space and knowledge mobilization points me to the fact that we need to be rethinking how are we delivering treatments, how are we addressing barriers to accessing treatment, and how do we work more with patients and families to get them connected with the care that they need. Next slide. And that leads me to the focus for this current research and for this talk. I want to talk a bit about connections between pain and substance use as foundation for the research that I'm doing. Next slide. So shifting gears a bit, wisdom tooth extraction. Wisdom tooth extraction is a common painful surgical procedure, one of the most common surgical procedures that adolescents and young adults undergo. It's a really interesting clinical encounter because majority of youth get their wisdom teeth removed, regardless of other medical and psychiatric comorbidities. Next slide, please. In the context of wisdom tooth extraction, about 1 in 3 youth experience pain or swelling before surgery. About 1 in 4 youth receive their first opioid prescription after wisdom tooth extraction. And about 20% of youth report postoperative complications, whether that is related to healing of their incision and dry socket or ongoing opioid use other than the way it was prescribed. Next slide. So when we're thinking about relationships between pain and substance use, there's still so much that we don't understand, but what we do know is that there's really this reciprocal relationship between the impact of substance use and pain, where for some people, substance use is used as a way to cope with pain that's not well managed. And on the flip side, there also is data to indicate that substance use can impact our sensitivity to pain and pain processing in the sense that both of these experiences impact each other. There's also a negative reinforcing relationship between the two. in the sense that when you're leaning on substances to manage your pain, you're going to continue to need those because it kind of helps in the short term, but then in the long term, not so much. Next slide. And so we have some data from the National Survey on Drug Use that indicates that pain relief is a common motive for opioid misuse among youth. You can see here in this graph when we're looking at to the far left there, what I have circled in red is the data for adolescents and young adults. And on the top, that really dark line is the percentage who report using opioids specifically for relieving pain. And there's so much more work that we need to do to understand and to dig underneath this. And is this related to unmanaged chronic pain? Is this related more to acute procedural pain? We don't actually know, but it is noteworthy that it's a very frequent motive for use. And we have evidence-based treatments that are medication and non-medication based for pain that we could be leveraging to better and more safely meet youth's needs. Next slide, please. And then my take-home message for this second part, for this second objective in the talk for you is that undertreated and untreated pain for youth has short and long-term impacts. This is an infographic from an organization in Canada. They work really closely with Solutions for Kids in Pain. I recommend checking them out. They have so many great evidence-based resources for providers, for families, for youth in regards to accessing pain management, behavioral strategies, medication strategies, advocating for a child, things like that. But what we do know from the data is that undertreating and not treating pain impacts the short and the long term. Next slide. Just highlighting some potential consequences of inadequate pain management. And we're talking more in the context of acute and procedural pain. So things like increased utilization, going back to your provider, going back to the emergency department. Negative pain memories and beliefs, that's a pretty salient one actually for youth, and especially early on. That's really salient with like vaccine-related pain, that can impact future experiences with painful procedures and needle pokes. Next slide. But we also need to be really, really mindful and really, really careful, especially if opioids are part of the mix here, that there are also consequences associated with over-managing pain related to opioid misuse or sharing opioids with someone other than who is prescribed, accidental overdose, respiratory distress, over-reliance on medications, and then GI types of side effects. So kind of back to what I was saying earlier in this talk, it is such a delicate balance between wanting to optimize the benefits and minimize the risks, and amidst all of that, be prioritizing pain management in youth. Next slide, please. And so in the work that I do, I really view that pain management is an essential part of a harm reduction agenda and is often forgotten in the conversation around reducing risks associated with opioid use and opioid misuse. And you know, our national data, there have been really phenomenal efforts to decrease opioid prescribing, decrease unnecessary opioids, engage in safer practices in regards to the number of pills, follow-up, things like that. But unfortunately, the story we see with overdose-related data, which is certainly not strictly from prescription opioids, but the story we see that overdose data continues to increase, and reducing opioids isn't enough. What are we offering in replace of opioids? What other strategies and resources are we offering youth and families to adequately manage their pain? Next slide, please. And so in the context of the intervention work that I'm presenting, I'm really thinking about pain from a biopsychosocial perspective. And this is kind of ingrained in me as a pediatric psychologist that, you know, we're thinking of both the biological factors in relation to pain, the surgery, the wound, things like that, but also psychological factors in regards to worry, stress, anxiety before surgery, and then social factors, the support, the resources that help youth and families be able to cope with and recover from surgery. Next slide. And it's my bias a bit, I guess I would say, that patient and family perspectives are really, really essential in this. At the end of the day, they're the ones who will be using the interventions that we develop. And I don't really want to develop interventions that nobody wants to use or that don't feel relevant to our youth. And so as part of this work, really working with them and working with families to understand what do you need and how can we better meet those needs. Next slide. And so the research I'm presenting on today, I just wanted to quickly share a bit of the background of where this research question came from. It actually came out of a scoping meeting that I attended with folks from Solutions for Kids in Pain. It was up in Ottawa, end of February, literally right before everything closed down from COVID. And they brought together folks from throughout Canada, really just kind of coming together about and talking about opioids in youth, talking about barriers that providers face, experiences from patients and from family members, and just what do we do? How do we adequately manage children's pain and address and reduce the potential harms associated with opioids? What was interesting at this meeting is that it was multidisciplinary, and there were a number of folks there who were dentists, and they expressed that they were really grateful to be invited to the meeting and often feel left out of conversations related to improving pain management and addressing opioid use. Next slide. And so that truly, conversations with them is truly where this research question came from. Thinking about common painful procedures in dental settings, thinking about my training in psychosocial and behavioral pain management and wondering, are those strategies being used in dental and oral surgery settings? And if not, how can we get them there? Next slide. And that brings me to talking about the current project, where we're looking to target both pain coping and substance use in youth in the context of wisdom tooth extraction surgery. Next slide. This is a 5-year study, and the first aim, which is the data I'm presenting today, is focused on collecting qualitative feedback from youth and parents to help us refine our intervention format and content. Step 2, which we're about to launch, is conducting a randomized controlled trial evaluating the intervention. Or I guess 2 and 3 are our intervention development and pilot RCT. Next slide. And it's important to highlight that engaging stakeholders and end users, patients, and families during intervention development has been shown to increase the acceptability, outcomes, and also engagement with an intervention. And so that's another reason why when I designed this study, I wanted to hear from patients and families at the outset. Next slide. We conducted one-on-one interviews over Zoom. Everything was done remotely with youth that reported past year substance use and their parents. Our interviews were transcribed, double-coded, and we did thematic analysis. Next slide. For our inclusion criteria, we were targeting teens between the ages of 15 and 20, the more common range for getting wisdom tooth extraction. Report of past year substance use, since part of the intervention is to specifically try and capitalize on this teachable moment and intervene on substance use. We wanted them to be engaging in substance use to have that perspective to share. And we recruited both teens who had upcoming oral surgery and who also were on the other side and already had oral surgery, because we were curious about if there were any differences before surgery, what they thought they would need in anticipation versus on the other side of surgery, and they had that experience to draw from. And then also included parents and caregivers, as family-based treatments for youth substance use are some of the most effective. Next slide. Just some characteristics of our sample. We did interviews with 30 youth. 15 were pre-surgery, 15 were post-surgery. Mean age was almost 19 years old, and about 70% of our sample was female. Next slide. And in regards to substance use behaviors, about a third of our sample on the CRAFT screener, which assesses frequency of substance use and consequences associated with use, about a third flagged up as high risk, which is more indicative of them potentially meeting criteria for a substance use disorder. And the most commonly used substances in our sample were alcohol, cannabis, and nicotine, which reflects national trends. Next slide. And then we also interviewed 21 parents. About 85% of our parent sample was female. Next slide. So let's jump into the results in the last couple minutes that I have here. And just briefly want to note, when we're talking, what we proposed as a brief intervention, we proposed doing a 1-session intervention where we met separately with youth and parents the week before their oral surgery. We're pulling from cognitive behavioral therapy for pain coping and motivational interviewing, motivational enhancement therapy for targeting substance use, and wanting to pull from both of those evidence-based treatments to address youth's needs in the context of surgery. Next slide. So we asked teens, we shared with them that handout of some of the content areas that we proposed to include, and asked for feedback about which of these content areas seems the most helpful, the most relevant. And overwhelmingly, youth were most eager to hear and most interested in learning more about medication and non-medication strategies to manage pain after surgery. I was kind of surprised they were interested for data on the effectiveness, wanted to know, like, how effective is it for me to be using ice packs and deep breathing versus taking Tylenol? And they also asked about working on mindset. So noticing that they had a lot of worried thoughts before surgery and what kinds of things could help them with that, which is actually right in line with CBT for pain coping. Next slide. This is a quote from teens. I'm going to skip over it for now, just in the interest of time. Next slide. The second thing that teens were ranked as most helpful was learning more about opioids as a possible pain management tool. In particular, across the sample, youth were pretty leery and pretty nervous about using opioids, didn't want to be prescribed opioids, and were pretty scared based on what they'd known in the media in regards to the opioid epidemic. Some youth shared having family members or loved ones who were directly impacted. And some youth also shared that they didn't really understand what opioids were and how they could help or how they could be harmful, and thought that would be helpful to have information about. Next slide. Next slide. Oh, there we go. And then the last piece I want to highlight, if you just go back quickly, is from the feedback from teens, is that they were open to talking about substance use in this context, but they were very clear that they wanted to know, how does substance use impact my healing from surgery? Should I stop vaping before? Should I stop vaping after? How long? And wanted to think of it as really a short-term thing, which really has impacted our design of the intervention to kind of characterize, how do we help teens make changes in the context of this short, acutely risky situation? And then potentially, could they capitalize and build on those changes over time? Next slide. Other teen suggested changes from the teens is the feedback was very clear that a 75 to 90-minute session was way too long. They said 30, 45 minutes max, and were like, get us the information as concise and brief and short as possible. It did not like the term intervention, so we actually now are framing it as a program rather than an intervention. They felt like that terminology was stigmatizing and made it seem like they had a bigger problem with substance use than they perceived. And the other big thing from the feedback from teens is their push to prioritize confidentiality in the context of substance use. A number of teens said if their parent had to participate, they would not be willing to participate. And others said, I would do it as long as you keep the parent and teen sessions separate. Next slide. And teens also were very clear that this needs to be a non-judgmental space. If they're going to be talking about substance use, be trusting a provider about it. This is not like a finger wagging kind of intervention of you need to stop, cut it out. They're open to talking about it. They're open to strategizing and planning, but it needs to be a space that they feel safe and not judged. Next slide. You can skip over this. I'm going to skip the parent context. Next slide. So a couple other observations is wide variance in youth's experience with wisdom tooth extraction. For some youth, they talked about it as the scariest, worst thing they've experienced. For others, they were like, it was not really a big deal. I don't know why I was so nervous about it. Um, Also, pain management, perioperative education experiences varied widely. And as I mentioned before, just kind of fear from youth around prescription opioids. Next slide. So just to wrap things up here, some implications for our program development. We actually shifted our program. It's not going to be clinician delivered. It's now designed online, a fully self-guided virtual format, because that really felt like the best way to make the information concise and consolidated. And also just thinking towards scalability, that having a behavioral health provider in an oral surgeon's office is not that realistic. We have also expanded our inclusion criteria because one, to protect youth confidentiality so that if they enroll in the study, it doesn't inadvertently disclose that they're using. And also because the pain coping skills are relevant to youth that are not using substances. And this is also an opportunity to deliver some substance use education and content for prevention for youth that are not using. Next slide. This is just an overview of the 5 modules that we have developed online. The first part is about science-based pain management because youth were like, do not start with substance use. We want to learn about pain first. We'll stop doing it if you talk to us about substance use first. Then we have a module specifically about opioids, then a module on considerations for substance use before and after surgery. And then I'm working to create a pain coping plan, really kind of carving out what are their options for non-medication, medication pain management strategies. Next slide. And so just key takeaways is that youth and families were enthusiastic and open to the content and thought that it would be helpful and useful. And that getting their feedback really shifted our intervention, our program format, and in a way that I think if we had just from the get-go proposed it, gone through and done a clinician delivered intervention, it makes me wonder if youth would have liked it as much and how that would impact our outcomes. Next slide. So we're about to launch the RCT this spring. And I don't have time to talk about it now, but it'll be a several month protocol, and we'll be collecting daily data from youth about pain, substance use, and recovery before and after surgery. Slide. So just a thank you to my mentorship team and collaborators, the phenomenal research assistants and students working on my team, and could not do this work without them. Next slide. And if anyone is interested, we'll be recruiting nationally since all our study procedures are virtual. So if you're interested in sharing this opportunity with your patients, please feel free to reach out to us. We'd love to hear from you. Thanks so much.
Thanks so much, Dr. Pielek. That was a lot of information, and I will share in the chat your email address and the information on the study. So thank you so much. And we'll come back to you for some questions and answers after Tiffany's presentation. So Tiffany, I'm going to turn the presentation over to you.
Thanks, Angela. Thank you, everyone, for being here. My name is Tiffany Wilson. I am the Director of the Office of Alternative and Community Responses here at the Office of the Attorney General. And for those of you who are regulars to these webinars, you will know us as the place where NJ Cares now lives. I spent 26 years as an assistant prosecutor in Union County, where I did a little bit of everything. So the very traditional prosecutorial work, but also work in the space where public safety and public health intersect, particularly in the world of mental health and substance use disorder. And I also spent a good deal of time being the assistant prosecutor who sat in an urban police department and heard what was going on from a police officer perspective. And so what I know from that 26 years is that officers are often the first entry or the first people who recognize that there is a crisis in their community. They were the first to recognize the impacts of opioids and in particular fentanyl. And they were the first to really want to help in that situation. And that's the work that we do now really comes out of that very unique position that law enforcement is in within the community and helping to lead efforts to make a safer and healthier community. Next slide. So while this work was being done in pockets in police departments, and sometimes an individual officer, maybe a community policing team who were really trying to help their community, in 2018, the Office of the Attorney General really took notice about what was going on with the opioid crisis, and really wanting to make an impact. And so Operation Helping Hand, the first of NJ Care's programs, what was begun. Operation Helping Hand is a county-based prosecutor-led outreach program where law enforcement officers are connecting individuals with substance use disorder or treatment and recovery services, particularly through the use of peers. Next slide. And it has taken many forms. It began as a really traditional law enforcement response. They would do sweeps. People were arrested in hotspot areas where there was a high incidence of opioid sales or opioid use. And then they use that arrest as an entry into treatment. But it has now grown and expanded and become more proactive. And now it includes things like a mobile van, prosecutor-led diversion programs in municipal courts, outreach specifically to defendants in the justice systems who are utilizing substances or have a substance use disorder. And it also is connecting individuals to treatment or recovery at arrest. So it runs the gamut. Next slide. So proactive outreach to individuals who are at risk for overdose. So where law enforcement and recovery coaches go to the individual's last residence, they knock on the door and they ask if there is a need for help can make those connections. Law enforcement also with recovery coaches go to hotspots. And then now they're doing what we call comfort calls, recognizing that there is a cycle of trauma and recognizing the impact that a substance use disorder or an overdose death can have on a family. They are also reaching out directly to families to hopefully help end the cycle and provide comfort to those families who have been impacted. Next slide. That's not where we stopped here at the Office of the Attorney General. So we knew that we were seeing several other crises as well in the mental health and public health space. And some of that was really impacted our law enforcement community directly. We were seeing a high rate of officer suicide, but we're also seeing, particularly for law enforcement, but also for lawyers and judges and those in the legal profession, a high incidence of substance use disorder within those professions. So in 2019, the Attorney General created the first nation statewide resiliency program for law enforcement, and that now sits in the Office of Alternative and Community Responses, where I get the privilege of leading that team. The directive recognizes that protecting an officer's mental health is just as important as guarding their physical safety. It tries to create a culture of support for law enforcement because we know that healthy law enforcement within a community helps to increase the health and well-being of that community as a whole. Next slide. And we didn't stop there. So in 2020, our Office of Public Integrity and Accountability, so those are the people who first rolled out the body-worn cameras here in the state of New Jersey and who investigate all in-custody deaths, was looking at that body-worn camera, were reviewing the data, and what they found was that 2 out of every 3 uses of force by law enforcement involved a citizen who was suffering from mental health or substance use issues, and that more than half of all fatal police encounters occurred in a similar circumstances. So those lawyers and attorneys in OPIA, so we like to call it, really looked at that data and said, that just can't be right. We're talking about an illness, and what can we do about it? And from that came the Arrive Together program. And Arrive stands for Alternative Responses to Reduce Instances of Violence and Escalation. Next slide. So in 2020, the Attorney General's office issued a law enforcement directive 2020-14, which first created a statewide framework for addressing mental health and special needs populations. The directive established working groups in each of the 21 counties that were led by the prosecutor's offices and law enforcement community, mostly because the Attorney General has directive power over them. So the Attorney General looked at this data and said, we've got to do something better in county prosecutors' offices. I am tapping you with gathering the local resources in your communities to talk about what's going on here, what are the driving factors for substance use disorder, for mental health, for the mental health crisis, what are the gaps, and how can we work collaboratively to fill them. And so that's how the working groups began. It was really the beginning of how Arrive came to be. Next slide. So in 2021, based on the input coming out of that working group and other work that was being done around the state by our law enforcement partners who were doing work in pockets around the state, as well as really just the Attorney General's mission to change those numbers. And in consultation with our partners at DHS, in particular DMAS, and community stakeholders, the Office of the Attorney General and New Jersey State Police piloted an initiative that paired the state police with and state police who were crisis intervention trained with certified mental health screeners and crisis specialists to respond to the 911 calls that involve behavioral health incidences. And that was the first of the Arrive Together pilots, and it happened down in Cumberland County. We picked the state police in particular because in addition to directive power and the multitude of other work that the Attorney General does, the Attorney General also oversees the state police. So that was a pretty easy lift in getting a law enforcement partner to the table. And then DHS, of course, is an amazing mental health partner for us. But we needed to see what would happen if we said that, if we wanted to see what would happen if this was an area that wasn't covered by the state police. So they tapped Union County as the next pilot to see what would happen if we asked municipal law enforcement to partner with us in this. And Union County, Lyndon and Elizabeth in particular, so I'm very proud of it. That is where I come from, have two really proactive chiefs and who really believe in community engagement and the benefits of making sure that their communities are healthier, and so they have prioritized training in the area of substance use disorder and mental health. And so those were our two first municipal pilots. Next slide. And what that has become in just a few short years is the Arrive Together program. So Arrive began as a co-response model. It was law enforcement officer and mental health provider in the car together. So we call that co-response. And when they're in that car together, the law enforcement officer is in soft uniform or what normal people would call plain clothes in an unmarked car with their mental health provider, because we know that sometimes it's the uniform, it might be the car, that could be a triggering event. And so we want to reduce all triggers before even first interaction. But in Atlanta County, they piloted a telehealth model to have a mental health provider available to law enforcement by the touch of an iPad, and then they can step away and that individual can have a conversation with a mental health professional if that's what's needed. We have a follow-up model as well. It's a very robust follow-up model where law enforcement who responds to a location recognizes that that this is really not a law enforcement related call, but in fact would benefit from behavioral health services, and they make that available to them through their trusted Arrive mental health partner. We also have a close in time follow-up, which is sort of a combination of all of the above, where law enforcement arrives on location and then taps in their mental health provider, but their mental health provider isn't in car with them. And that really works in our rural areas that may not have the volume, but do have the need. And so they can't dedicate an officer that's in plain clothes for an entirety of a shift. But they do recognize that they do need that mental health partner with them. And then our newest model, our critical incident Arrive model, which is a very intentional partnering of law enforcement and a mental health provider on cases that involve what we would refer to as a SWAT team or hostage negotiation situation. So like a barricaded subject, for instance, where those teams now have as part of their team, or will shortly, a mental health provider that is working alongside with them. Next slide. So again, in a very short amount of time, Arrive is now in all 21 of New Jersey's counties, which means that we're providing a mental health resource to law enforcement and they are interacting with someone who would benefit from them. And it means that we are providing that resource to the communities that they serve. New Jersey is the first state to have a program that spans the entirety of the state. We know that there's great work being done nationally in some large and small cities, but we have been the first to be able to successfully expand that throughout the state. And we do think that that is partially because, or mostly because of our partnership with DEMAS, and the fact that we are not creating a new mental health system. We are utilizing the systems and the resources that are available, not only on the state level, but on the county level, utilizing those mental health special needs working groups. So the teams that create Arrive programs in each of the counties and sometimes in each of the municipalities are tapping into the existing resources, but they're using the access that law enforcement has to the individual in need to bring the resource to that individual, rather than creating an entirely new system, which has really proven to be very efficient. It's also been very cost effective. And King University was our first institution of higher learning to participate in Arrive, though we have several others that are now joining, which provides an Arrive program on campus that is specific to the needs of the on-campus community, but it also helps us to partner with our colleges and universities across the state to help strategize how we can help them enhance their learning opportunities on campus and hopefully attract more mental health providers to come and study and stay in the state of New Jersey and help us address the crisis that we're having in being able to have enough mental health resources here in the state. Next slide. Arrive is providing safer outcomes for our most vulnerable individuals. Having a mental health specialist rather than an officer address behavioral health concerns is keeping residents safe, but it's also making job satisfaction for those officers much greater. We're not asking them to step out of their lane and try to be professionals in an area that they weren't specifically trained to do. And we are seeing fewer arrests, fewer uses of force, fewer injuries, and we are eliminating racial disparities with respect to the outcomes. We have had over 7,500 Arrive interactions since inception, and our data bears this out, and it's all available on our website as part of our Arrive dashboard. So you can follow us along and watch our progress. Next slide. We're also increasing the utilization of mental health resources, and because, again, of those mental health special needs working groups and having everybody at the table to identify gaps and needs within the community, we are also seeing an increase in the use of substance use disorder or substance use resources as well. And I cannot reiterate enough the fact that these are locally based resources, which make them more easily accessible, but even the partners understand what the resource availability is, and they are making amazing connections to address the whole person. We know that there's a high incidence of co-occurring and many court-based programs really make individuals or professionals have to differentiate what is the diagnosis of this individual. And Arrive does not do that. It really meets that person where they are using community-based services along the way. And we know that traditionally law enforcement officers, when they're interacting with a person in crisis, no matter what the cause of that crisis is, really had two options: to call a screener and wait, because of, again, that the crisis that we're having in hiring mental health professionals across the country, but also definitely in the state of New Jersey, or that, consistent with the law, make decisions to transport the individual involuntarily to a hospital, which increases the opportunity for uses of force. And then there's that third unmentioned option, which is arrest. And it was law enforcement saying, I don't have another tool in my toolbox, so all I have is arrest. So that's what I'm going to do. Next slide. But Arrive instead keeps people in the community. Our friends from DHS tell us that 1/3 of the individuals in crisis who are transported to, only 1/3 transported to the ER actually require hospitalization. So we're decreasing the burden on our system. Next slide. We're also improving trust amongst law enforcement and the community that they serve. And because Arrive is community informed and designed, it fits the needs of the specific community and the individual that they're serving. Next slide. Because of the success of Arrive, we've created the Office of Alternative and Community Responses by directive in 2024. So our 1-year anniversary is in fact today. We have our Opioid Prevention Bureau, that is where NJ Cares lives, our Resiliency Bureau, our Law Enforcement-Led Alternative Policy and Program Bureau, and that is really giving those resources to law enforcement as one of the entry points for individuals who are seeking help or who are in need of help, and their families. And then our Diversion Policy Bureau, which works on the diversionary work in partnership with the Office of with the court system, so the AOC, Administrative Offices of the Court. Next slide. And OACR's complete mission is to be the intersection between public safety and public health for here at the Department of Law and Public Safety, and the over 8,000 individuals who work here and the 24 offices and divisions that are part of the department. And the directive specifically recognized that when we silo our work, that we are not doing anybody any favors. We have to stop siloing mental health, substance use, intellectual and developmental disabilities, and just provide the community, our law enforcement officers, with the resources they need to help somebody find the connections that they need. Next slide. These are all things that we already know, that we are in the midst of a crisis, and this is really what we're trying to address. Next slide. But we also know that the demands on our system and those who work within the system are too great, and we need to do something. We need to provide them with the resources to address and to help the community that they serve, but we also need to make sure that they have those resources for themselves. Next slide. And we know that in order to do that, we have to be innovative in the way in which we do these things. That is really what the work of OACR, as we like to call it, is to do. Next slide. I've listed some of the key goals, which I know you're going to get the slides, but I think one particularly for this particular group is that the goal of OACR is to prevent crime and involvement with law enforcement through supportive and community-led strategies and partnerships that combat addiction and the conditions leading to it, as well as other issues at the intersection of public health and the criminal justice system. And we think that law enforcement can be a key player in that and is helped leading the way. Next slide. And you can go through the next few. You know, we are prioritizing resiliency next, as well as how law enforcement responds to these issues that are really more public health driven. Next slide. And we want to improve public safety through our innovative programming, whether it comes from the prosecutor's office or law enforcement. Next slide. And these are our bureaus, as you know. NJ Cares is our opioid related work, and you can go through the next two, I think. Next one. Oh, one more. And this is, there we go. And so in our law enforcement-led work, that is our Arrive Together, our Operation Helping Hand, as well as our law enforcement-assisted LEAD program, another community-driven program that really gets to the heart of why someone may, the underlying causes of things like substance use disorder, and then our opioid response teams. Next slide. And then there are community crisis response teams now by statute in 5 of our communities. And that's really using trusted messengers and really community-based organizations to help us connect this work. Next slide, which I think is the end. Oh, there we go. So thank
That's
you all.
perfect.
I know it was a lot of information today, but hopefully it was helpful.
It was a lot of information, but important information. I'll give you a minute and we'll go to Dr. Peelik with the first question. Dr. Peelik, can you just talk a little bit about the role parents play and parent consent in the strategies that you talked about and in your study?
Yeah, for sure. Thanks, Angela. I saw a comment in the chat around that, and it's important to clarify that we're testing this intervention in the context of research, and so for teens that participate, we absolutely still need parental consent for their teen to participate. What we shifted is that previously both parent and teen had to participate together to be eligible for the study, but now the teen can choose to participate on their own if their parent doesn't want to or if they don't want their parent to participate. But we
Right.
certainly do absolutely still need youth assent and parent permission.
And in general, though, outside of even your study, what role do you see parents playing in?
Yeah, parents and families are so key. That's a good bit of the work that I also do, engaging families in youth opioid use disorder treatment. And families are so crucial with helping youth to engage in treatment, maintaining in treatment, and also supporting them outside of treatment. We see them for such a small amount of time of their lives. And so if we can equip parents with skills to help with communication, engaging youth in healthy social activities, that usually tends to lead to better outcomes. Changing behavior is hard. It's hard to do it on your own. That's why we need families and families broadly defined, other support persons too.
Absolutely. Thank you. And Tiffany, we have a lot of community leaders on with us as well as prescribers and EMTs and other professionals. What can they do to help you share the message about this important program? Is there any role and why is that important within the community?
Yeah, I think it's really important. Obviously, my first, I would your entry into that would be contacting your local prosecutor's office and finding out about those mental health special needs working groups. They definitely need the perspectives of all of you in that work, but then they also need your help in getting that word out. So you mentioned EMTs, and I think it's them having conversations with their law enforcement counterparts and asking how they can help. And we know that everybody is always looking for training, but what we've found from Arrive is it's that real, not classroom training, but it's that collaboration together. And so, your law enforcement partners want to hear what an EMT's experience is, but I think it's also really helpful for you to know what they're experiencing when they're in the car with that mental health provider. And I think that's something that we have found through this is that just putting everybody in the same room, sometimes in the same car together, and sharing that information is really where we're seeing the sort of bread and butter of Arrive. It's in collaboration and conversation. So I think it's inviting yourself to the conversation if you're not there yet, and then offering to help spread the word.
Well, that's a great comment to end on because I think from both of you and both of your presentations today, the idea that together so much more can be achieved, right? And as we look at a community response and how significant that is, so I want to thank you both for your time today. We probably have about a minute to get a final thought from you, but before I do that, I just want to thank all of our attendees for being with us today. Information is on the screen about how to obtain credit. There's also a poll I hope that you'll complete and give us some feedback about today. And I hope you'll join us on April 10th for our next conversation during Alcohol Awareness Month, the link between alcohol use treatment and opioid related harms. But Dr. Peelik, we have about 30 seconds if you want to just give us one last thought to leave on for the day, and then Tiffany will end with you.
Um, I think just a last thought for the day is when we're working with youth in the context of substance use, considering other pain related medical needs, and also remembering the importance of maintaining a non-judgmental open stance when we're talking with youth. They're really trusting us, and it's a really crucial conversation when youth disclose substance use in the context of their healthcare. And we have a lot of space to make a big impact, positively or negatively, in that conversation.
All right, thank you. And Tiffany, if you can give us a
Yeah,
last thought.
absolutely. One, I just want to point out there's a misconception that law enforcement, I'm often asked, why does law enforcement buy in? And I will tell you that law enforcement is overly excited about the Arrive Together program, and we've been really excited. And the other thing I get a lot is, well, now that you're not co-responding, what is the together arrive together? And I say all the time, it's because together we can address these issues, and it takes all of us together to do that. So I think our name stays the same, and I think that everyone, at least in the state of New Jersey, can be heartened that your law enforcement community really just wants to help, and they're very excited that we're giving them these tools to do that.
That's perfect. Thank you so much. Again, thank you to our expert panelists for being with us today. Thank you for all of our attendees. We put some information in the chat, some resources, and you'll get a follow-up email within the next 24 hours. So thank you again, and I wish everyone a good day. Be well.